Good morning and welcome to Southern Maine Healthcare's Medically Speaking. I'm your host, Robert Erickson, and for the next 30 minutes, you'll hear about medical issues and topics of the day directly from leading medical professionals at Southern Maine Healthcare. Welcome to this week's Medically Speaking. Our guest today is Dr. Christina Cinelli. She specializes in radiology and is co-medical director at SMHC Diagnostic Radiology. Dr. Cinelli, thanks for being on the show.
Thank you for having me, Robert.
We like to start our interviews with talking about how you got into the field that you're in. How did you get interested in medicine, and how did you end up with a specialty in radiology?
Well, I always liked the sciences growing up and thought about being a doctor in high school. Then when I went to college, found an interest in art history, so explored that for a little while, but then circled back after college and entered med school. I went to Brown Medical School in Rhode Island, and at that time found radiology very interesting. I think with art history as a background, I was really drawn to imaging, and I liked the diagnostic nature of radiology. Specifically in radiology, actually what drew me most to the field was the area of breast imaging, because it was a mixture of using imaging to diagnose, but also seeing patients.
And what brought you to Maine and Southern Maine Healthcare in particular?
Well, I'm actually from Maine originally. I grew up in Yarmouth, and my parents and sister still live around here, so it was nice to come back. My husband went to camp in Maine and wanted to move here, so we both decided that this would be a good fit. There was a great job available to me at Spectrum, and Southern Maine Healthcare is one of our main breast imaging sites, and since I do breast imaging, it's been a natural fit.
So can you tell us about the different types of radiologic diagnostic tests available and how they differ and what they're typically used for?
Sure. Radiology is not necessarily something that everyone's familiar with, probably until you've actually had an x-ray, and then you start to think, oh, okay, there's someone who takes the picture and someone who interprets it. So it's not something that you think about every day. But basically, there are a variety of different tests that we use for diagnostic tests in radiology, and the most basic one is an x-ray. So for a chest x-ray, if you have pneumonia or if you have a broken bone, you might get an x-ray of your finger or your arm. If there's something wrong with your belly or you're having abdominal pain or chest pain, then sometimes you get a CT or a CAT scan. And we also use ultrasound for imaging, so that can be done on really any part of the body. We use a lot of ultrasound when doing obstetrics exams. Also, there's newer technology like MRI, which we use for a lot of soft tissue evaluations. So for instance, if you have a shoulder injury, you might get an MRI of your shoulder, because then we can really evaluate the ligaments and tendons. And the MRI shows us things that we really can't see on X-ray. X-ray really shows us just bones. And for breast imaging, you have different options. There's mammography, which is sort of the baseline screening exam, but we also use ultrasound and MRI for additional imaging evaluations.
So do all of those tests involve radiation?
So not everything involves radiation. X-rays and CTs are the primary exams that give radiation to the patient. Oftentimes it's a very low dose radiation, but it still is a radiation. Also, there's some nuclear medicine tests that do have a radiation component to them. And if you have any questions about that, you can always ask the technologist who's taking the exam or read about. There's a lot of information online about X-rays.
So we specifically want to talk today about mammography and the advances that have been made in detecting breast cancer. Can you talk a little bit about that?
Sure. So we typically use mammography as a screening tool for breast cancer. A screening tool is one that is low cost and easily available. So mammography fits those two characterizations. And that being said, mammography is not perfect for detecting breast cancer, so we're always looking for ways to improve mammography or possibly other techniques or exams that we might use for screening for breast cancer. But mammography is very generally just an exam where the patient comes in and their breast is compressed in two different directions, and we use those images to evaluate for breast density and if there is any sign of cancer. So our sort of what we've been doing for quite some time is called 2D mammography, and that is where we just take a picture and you have one image in each projection that you evaluate, and oftentimes there are limitations to that exam. For instance, if you have dense breast tissue, then the tissue can overlap and could either obscure a lesion, or sometimes the tissue overlaps to mimic a lesion, which really when there isn't one that's there. So sometimes people get called back for additional imaging, and we have to work up those findings.
Now, I understand that there's a newer technology that helps you better see all the layers in the breast, especially a woman with dense breasts. Can you tell us more about that?
So one of the newer technologies and advances in breast imaging, particular mammography, is 3D mammography, or sometimes called tomosynthesis or digital breast tomosynthesis, DBT. There's a couple different names. I think many people commonly refer to this as 3D mammography. But this has been a recent advancement in the mammography technology, where we are actually able to take imaging of the breast where we have multiple slices of images that we stack on top of each other and we say scroll through the images. And so it allows us to evaluate the breast tissue in a more three-dimensional manner, and evaluate whether or not the tissue that we see that's dense is just overlapping tissue, or perhaps if there may be a spiculated mass or cyst or some lesion hiding within the breast tissue. So it's really been quite a great development from our perspective, and I think patients have also been happier about it. There are a couple different benefits which patients like. One is that there's been a decrease in callback rates. So that's, as I mentioned before, sometimes patients end up coming back for additional imaging because we're not sure if there is an abnormality on their mammogram and we want to evaluate it further. With the tomosynthesis or the 3D mammography, we are often able to decide at the time that they get their screening exam whether or not this is a real finding or whether or not it's just overlapping tissue. Typically, in a screening panel of about 1,000 patients, around 10% of those patients might be called back for additional imaging. With 3D mammography, there's been studies that have shown that it's decreased the callback rate, and we actually have in the about 6 months that we've been doing it here at Southern Maine, have seen a decrease in our callback rate. So that's a great benefit. The second main benefit to the tomosynthesis or the 3D mammography is that it actually helps detect more invasive cancers. So the way that we see a cancer is easier on the tomosynthesis or the 3D mammography than on the 2D, and so we actually are able to detect more invasive cancers, which is nice because those are the cancers that we need to be treating. And again, there have been studies that have demonstrated the benefits of tomosynthesis in detection of invasive cancer, anywhere from 15 to 20% increase in detection of invasive cancer. So again, another benefit to this new technology.
So what makes a cancer invasive versus non-invasive in the breast? Yeah,
so there's a sort of spectrum of cancer growth, and because the breasts are made for producing milk, the main component of breast tissue is ducts. And so typically there are a couple different types of cancer, but one of the primary cancers that you see in the breast is a ductal carcinoma. And this cancer typically grows within the ducts. And when we say it's just in the duct from a pathology standpoint, then it's in situ, or DCIS is a more commonly used term. However, once the cancer starts growing outside of the ducts, then we consider it to be invasive. And those are the masses that we see on mammography that often appear spiculated or have a spider type appearance and can cause distortion in the breast. And so those are the kinds of things that we look for in mammography.
And because those can be so fine and small, the traditional mammography doesn't see it as well?
Yeah, so one of the things that makes cancers hard to see on mammography is partially in combination of the patient's background breast tissue density, but also because when you have on the 2D mammography, you just have a single image that you're looking for, you don't really appreciate the volume of the mass. Whereas when you have the 3D imaging and you're able to scroll through those images, you're looking at that cancer and taking multiple slices through it. And so you really appreciate the margin and the mass in a just an easier way. It just kind of jumps out at you often. So from an imaging perspective, it's a much more satisfying experience to read the 3D. But again, it makes you feel more confident about calling abnormalities.
And I would imagine it's better for the oncologists and surgeons to have a better view, a better image to work from. Is that correct?
Absolutely, yeah. I mean, I think everyone feels more confident when looking at the tomosynthesis images, the 3D images. And I think that it allows us to evaluate other areas of the breast more thoroughly. And I think we've seen a combination of a decrease in additional images that are needed when patients are called back. So if we see a mass, sometimes you don't end up getting additional mammography images. You just go straight to ultrasound to evaluate for a mass. And sometimes if the patient has cancer and the surgeon wants to evaluate additional areas in the breast, if the tomosynthesis is negative, then they feel more confident there's nothing else going on. We may not see as many MRIs preoperatively, and that's a little bit surgeon-based. But, I think that it really has overall improved our ability to detect cancer, but also to manage patients in general.
So is 3D mammography only used for detecting and treating breast cancer, or are there other uses as well?
So, we sometimes find benign things in the breast. And so, obviously, those things tend to be incidental. We usually make sure that they're not cancer. Mammography is generally just for screening for breast cancer. But there are other types of imaging studies that have a component of tomosynthesis, sometimes in some urology exams, and I think that we're continuing to explore the use of tomosynthesis and evaluating other areas of the body as well. But for now, I think breast is really the mainstay.
So does 3D mammography expose the patients to more or less radiation?
So the short answer is no. When tomosynthesis or 3D mammography first came out and was, they were kind of experimenting with it, patients were getting both 2D and 3D imaging. So at that point in time, they were getting more radiation. But now we are able to create a 2D image from the 3D information that we get. And so that we call it a synthetic image. And that helps us compare to priors and just have a single view that we can look at for simplicity's sake from the get-go. But now we just take the same projections that we did in the 2D, but we are using 3D technology, and the radiation is the same, if not lower, because the 3D mammography required many updates in the machines that we use to take the pictures. And so with advances in technology, they've actually been able to decrease the amount of radiation that it takes to do a single mammography study. And so the radiation is the same, if not a little bit better.
You're listening to this week's episode of Medically Speaking, and we're talking with Dr. Christina Cinelli from SMHC Radiology about advances in 3D mammography, and we'll be right back with more of our discussion right after this.
Not every boo-boo is an emergency, but it still feels like one. That's why Southern Maine Healthcare offers walk-in care. You'll find compassionate care at wonderfully convenient locations. Open 7 days a week, no appointment necessary. For those times when the unexpected happens, or you're just not feeling great, look for the orange ball as your sign of the best walk-in care. In Kennebunk, Saco, Waterboro, and Sanford, Southern Maine Healthcare, a member of Maine Health.
We are back with our guest, Dr. Christina Cinelli, and we're talking about 3D mammography. Is 3D mammography going to completely replace 2D? Because it seems like why would someone get 2D when the 3D is available?
Right, so that's an excellent question and something that we have been dealing with since implementing it here in Southern Maine at Southern Maine Healthcare. I would say that, because we are doing a screening test, many insurances cover a screening test. However, with the rollout of 3D mammography, not all insurances initially covered it. So we were offering patients both the option for 3D or 2D. And initially, because there was sort of some some flux in the insurance coverage, many patients were still getting 2D if insurance didn't cover it. Now it seems like all the insurances are on board and are covering it. So we've seen a significant increase in the number of people getting 3D mammography. I would anticipate that in the next few years, we will basically just be doing 3D mammography, and the 2D won't really, be an option. But the machines that do the 3D can always do the 2D, so it's not something that the patient should have to worry about from a technological standpoint. But of course, many patients have concerns over expense of an exam, and I always recommend that they check with their insurance provider initially. But now in 2018, many insurances are covering the 3D imaging, which is great.
So can a patient specifically request the 3D mammography, and is there any reason that a provider might not recommend that?
Well, from my perspective as a radiologist, I don't see any reason not to get the 3D imaging. Some patients who have entirely fatty breasts, the 2D mammography is probably essentially the same, and don't really necessarily see a huge benefit to the 3D imaging in those patients. That being said, if there's a skin lesion or a small lymph node and a totally fatty breast, the tomosynthesis, the 3D imaging can really help us determine that, that's exactly what that is, and the patient doesn't need any further imaging. And so my hope is that, patients coming in for screening exams will, as time goes on, just get the 3D imaging. There are situations where patients have calcifications that need additional imaging. In those situations, when we take magnification views on callbacks, those patients do get 2D imaging because with the calcifications, we like to magnify them in a 2D image. So there are certain instances where we don't always do 3D, but as in regards to the actual screening exam itself, I would anticipate in the next few years a transition to just 3D imaging. And I would think that that's a trend across the nation.
Does a patient need a referral to get a mammography?
So you do need a order from a doctor to get a screening mammogram. And I always say to talk with your doctor if you have any questions about 2D or 3D mammography. You can also talk with the radiology department, and the referring provider has the option to order both, or either a 2D or a 3D study. And when you come to have your exam, you also have the choice to change that. If you don't want the 3D or want the 3D, we have the ability to accommodate that. So you just need an order for a screening mammogram from your doctor, primary care doctor, OBGYN, family doctor, whoever can write you a prescription for that.
Now, I know it's rare, but men can also get breast cancer. Have you ever performed any diagnostics on men?
Yes, we do actually, and about 1% of the breast cancer diagnoses are in men. Last year in 2016, we had one diagnosis of a male breast cancer, and which was about out of about 100. So I guess we're meeting the statistics there. But yeah, we do mammography on men for a variety of reasons. Men can get the tomosynthesis, and it actually helps. There are a number of benign things that can happen in the male breast, and so we don't always see men just to evaluate for cancer. But if they have a lump, we will oftentimes do a mammogram and an ultrasound. And men who have family history of breast cancer, who are considered high risk, if there's a BRCA gene that's positive in their family or another variety of genetic abnormalities, then oftentimes those men will get screened for breast cancer. So yeah, we see a fair number of men in our practice.
Can you give us any examples of when a 3D mammography improved a patient's outcome?
Well, I think sort of just something that we see every day. And again, it's a little bit basic, but in many situations where the patient has dense breast tissue, where on a 2D mammography, you might say, I'm not sure that maybe that's an area of asymmetry, or, it looks like there's some overlapping tissue, but I'm not sure. Could there be a mass there? On the tomosynthesis, the 3D imaging, we can scroll through those images and confirm, no, it's just overlapping tissue. Or you can confirm, yes, there is a mass. And again, that patient goes straight to ultrasound and skips the additional mammography images. So again, just a little bit less radiation, one less study to have to go through. But I would say, as far as diagnosing cancer, there's a couple different cases where I've had a screening exam where there's just a tiny bit of architectural distortion where it just looks a little spiculated, and patient came back. Because we called her back, we had her get additional imaging and an ultrasound, and she actually had quite a much larger mass than you could actually appreciate on the mammogram. But had we not had the tomosynthesis, there's no way we would have seen that little bit of distortion because it just would have blended in. So, and that patient was, I think, 45. So for her life, I feel like we really made an impact on her life, and feel like we wouldn't have been able to see that without the tomosynthesis.
Now, I know there's been some controversy about when women should begin getting mammograms and how frequently. Can you tell us what the guidelines currently are?
Sure. So there is a little bit of variety out there about what the recommendations are. I would say generally many healthcare organizations and health groups recommend starting between 40 and 50 and annual exams. As a radiologist, I adhere to the American College of Radiology and the Society of Breast Imaging, where, again, they recommend starting at 40 and screening annually. Here at Southern Maine Healthcare, we are a part of Maine Health, and there is an organization within Maine Health called the Maine Health Breast Work Group, and that's composed of oncologists, radiologists, pathologists, radiation oncologists, and many other support staff. And they came out with a recommendation to start at 40, but then to either do screening every 1 or 2 years after that. And, I think there are primary care groups that might follow the U.S. Preventive Task Services Force. They, recommend starting at 50. The American Cancer Society recommend starting around 45 and then screening every 1 to 2 years. And again, a lot of the recommendations of different organizations are a little bit in flux. So I would, refer to the official website or statement that any healthcare organization would make. But in my experience, I think that for a normal risk patient, starting at 40 is a great idea. If the patient would like to have a conversation with their primary care doctor about their preferences, I think that's a really great idea. We're always happy to talk to patients if they have questions. For anyone who's high risk, that's a little bit of a different situation. And so again, I would advise any patient who has questions about this to have a conversation with their doctor. And we're always available as a reference. There are a lot of resources available online. And again, I think if there are any specific questions, we're always here to help. And just as an example, I was looking at the data for cancers that were diagnosed in 2016 for Southern Maine Healthcare, which we had almost about 100 cases. Of those, 20% were diagnosed in women who were less than 50 years old. So that is a significant amount in my opinion. I think when you look at some of the Maine Medical Center data, you have some similar statistics. And I don't have the comparison of how that trends with the rest of the nation. But again, I think I tend to follow my own organization's recommendations to start at 40. But I think the most important thing is that patients talk with their doctors and have kind of joint decision making. But we're always available here as a resource.
Now, if someone's interested, where can someone get 3D mammography in our area?
So for Southern Maine Healthcare, we have a variety of different sites where you can get imaging done. It can get a little bit confusing, particularly when it comes to mammography, because we have updated a few of our machines, but not all. And the hope is to be able to have updated all of our machines in the coming years. But at the current time, you can get a 3D mammography at Biddeford campus or at the Sanford campus. So if there's any question, you can ask your doctor, or when you're scheduling your exam. And if you want the 3D study, make sure that you ask the scheduler to schedule you either at the Biddeford or the Sanford campus.
If someone does have questions, is there a number that they can call?
Absolutely. So I'll try not to say this too fast, but if there's any questions, patients can call the radiology department at 207-283-7824. So
Dr. Cianelli, is the 3D mammography used for any other purpose besides the obvious one?
Well, so one of the things that has happened since we started using this new technology, it is more or less the same, but it's slightly different. And so we're seeing the breast tissue in a more detailed manner, and sometimes we find very subtle abnormalities. One of the things that's nice about the 3D imaging is that we are able to actually do 3D guided biopsies. And that is great for those little tiny asymmetries or areas of architectural distortion that you really don't see on the 2D exam. We have a special biopsy unit called a stereotactic biopsy, but it's able to use the 3D imaging for a technique and approach, and that has been fantastic. And we've been really happy with that. It's a really easy and quick way of getting a small bit of tissue, and I think patients are overall happy with that. And again, these cases, we probably, before having the ability to biopsy, would just have to go to excisional biopsy at surgery. So the fact that you can do a biopsy in our office takes about 10 minutes is pretty amazing.
So it sounds like it would be much less invasive, shorter recovery time. You don't have to undergo anesthesia. Is that correct?
Absolutely, yeah, really. And, getting a tissue diagnosis, and sometimes those patients end up having surgery because it's cancer or something atypical that needs to come out, and sometimes it's just normal tissue, and then we move on, no surgery. So it really saves a lot of resources and time and money for everyone involved.
You talked a little earlier in the conversation about ultrasound. How does ultrasound complement what you're doing with the mammography?
Yeah, so really we use ultrasound in a variety of different ways within breast imaging. Oftentimes, if the patient's less than 25 or 30, we typically won't do a mammogram initially to assess an abnormality if the patient has a palpable abnormality or pain in their breast. If they're less than 30, we don't do mammography as the initial test. We start with ultrasound, as ultrasound does not have any radiation. So that's been really helpful. I think for people with dense breasts, ultrasound is sometimes an adjunct for screening, and ultrasound is great for palpable abnormalities. And we also use ultrasound as the mainstay for any procedures, biopsies that we do where there's an abnormality that you can see by ultrasound. It's very easy to do an ultrasound guided biopsy, minimally invasive, very little recovery time, and very fast procedure. So we're able to get tissue for the diagnosis in a very swift way. And ultrasound we use for localization, for helping the surgeon in the operating room. So there's a variety of reasons that we use ultrasound, and like you said, it really is a nice complement to the mammography.
Now, are there things that women and men can do to prevent getting breast cancer in the first place?
Yeah, so that's kind of a complex question, but I'll give you some of my thoughts. There's a couple different ways to think about breast cancer. There are some patients, the patients who have a BRCA positive gene, either BRCA1 or BRCA2, they're in a very high risk category. Those patients tend to take prophylactic measures that are usually surgical. And again, those patients are kind of in a different category than many people in the general public. For people in the general public, sort of who are normal risk, the three things that I think about for reducing your risk for breast cancer is number one is to exercise and have good weight control. Number two is to not smoke. And number three is to have a low alcohol intake. So those are the three things that have been shown to decrease your risk for breast cancer. But I think healthy living is great. It's probably easier said than done in some ways. But the three things that I really focus on are the three that I just mentioned. So that's what I always recommend for patients. And I think that's just good advice for all of us.
Well, thank you, Dr. Cinelli. This has been a very informative session, and we enjoyed having you on the show. Thank you for appearing on the show.
Thanks so much for having me. And I'd just like to say I really enjoy working at Southern Maine Healthcare, and I think we have a really great breast center. If any patients in the community have any questions, we're always available. There's I'm just one of many on this team. We have a great breast surgeon. We have fantastic nurse navigators, pathologists, radiation oncologists. So it really is an oncologist. It's really a team effort, and I think that the breast center here, it's an NAPBC accredited breast center, and we provide some fantastic care. So I'm proud to be a part of that team.
And once again, if people want to get information, if they want to call or contact you, what's the easiest way for them to do that?
Absolutely, yeah. Anytime you have any questions, just feel free to call us. The number, as I said before, is 207-283-7824. And also there's a area that you can access on the web at the Southern Maine Healthcare website, which is www.smhc.org. And then once you get to that main page, look for the Care and Services section, and that will allow you to find resources on the breast care center, any of our oncologists, any questions that you may have. And please do not hesitate to call. We're here for you.
You've been listening to Medically Speaking. I'm your host, Robert Erickson. Join me next week at this time for a new guest and an enlightening discussion about healthcare in our communities. Brought to you exclusively by Southern Maine Healthcare, your trusted resource for healthcare in Southern Maine.